Hello, I'm Mary Beth Marsden, and welcome to GBMC's Greater Living. This is a place where each month we talk about a specific health topic. And of course, today we're also going to be talking about COVID, which I think is casting a shadow over everything else. But we're talking also about thyroid, your thyroid, our thyroids, and different conditions involving the thyroid, what the thyroid does exactly. And we'll be speaking also about really serious conditions like thyroid cancer and talking about surgery and so forth and different therapies that are available. But joining us now, we're happy to have Dr. Ray Blanco, who is the medical director of the Milton J. Dance Jr. Head and Neck Center Head and Neck Surgery. Dr. Blanco, thank you so much for being with us.
Thank you very much, too.
You know, before we launch into talking about the thyroid, I just have to ask you, and I know you're not in the emergency room or in the ICU on a regular basis, but from your perspective, how is COVID right now affecting the hospital from what you can see?
Well, the hospital is following the standard precautions followed by the governor's issue. So we canceled all our elective cases except for emergency and cancer cases. Those emergency and cancer cases will continue to be treated appropriately and timely.
A difficult place to be back to for you. I think we experienced this early on 2 years ago when we had the first lockdown, and people who were concerned about their thyroid probably put off getting tested or being seen. Now I know we're doing so much more virtually, but still you need to see people, right?
Yeah, so as you can see in some journals right now, the world of medicine has shifted partially to telemedicine, and we can actually do telemedicine and discuss the signs and symptoms, what the patient's having. And from there, we can direct the patients to do an ultrasound and the thyroid, and we can discuss this virtually. However, it also requires a presence of the patient in the clinic, in which we will explain face to face what are the indications for surgery and what are the non-surgical indications, why you should have surgery and why you should not have surgery.
Do you feel at this point, as compared to 2 years ago, that your department is better equipped to sort of pivot and balance the situation at hand and still help your patients?
Yes, we are. We were prepared before all of this COVID, about 2 years before COVID hit. Our team in the Milton J. Dance were already working on our telemedicine program. So we have a head in the way we run our telemedicine program. So when actually COVID hit, we were already set up for telemedicine. So that really helped both the staff and the patients. And there was a limited break on the continuity of care for thyroid patients.
Okay, so let's talk about the thyroid. We've all heard about the thyroid. I think we have a sort of an understanding about what it is and what it does, but explain the basics to us.
So let's go first to the anatomy. The thyroid is like a butterfly shape. It's in front of your windpipe or your trachea. The function of the thyroid is for metabolic purposes. It's helpful when it comes to stress. It's helpful for development, growth and development, and really, really important, especially during the early phase of growth, especially for children. And if you have some thyroid problems, it can also affect the like cleft palate can develop in those kind of cases. That's why patients who are in the OBGYN service, their thyroid function is really checked. Now, for the non-OBGYN patients in which the thyroid gland, the most common presentation is they feel something that is enlarged and they have compressive symptoms, in which case they will go to your primary care and will be worked up. Usually the workup is ultrasound and thyroid function test, and from there determine whether the patient is surgical and non-surgical.
So when you say they feel something, they feel like a lump?
Yes, sometimes they feel like a lump in the neck, and that's one of the most common presentation. And they will go to the primary care and saying, "Hey, I feel a lump in my neck, and every time I swallow, it's difficult." So those are just one presentation. The other thing is what we call incidental finding, in which the patient is asymptomatic and undergoing other workup, and when they do imaging, they see the thyroid is enlarged. And in which case, again, the workup doesn't change. The workup will be again biochemical labs and thyroid ultrasound, and from there determine whether this is a surgical or non-surgical. And at times, if there's any suspicion of the nodules, do a ultrasound guided needle biopsy.
Do we know at this point why someone's thyroid might get enlarged?
Well, that's a good question. So, first of all, the most common reason why the thyroid get enlarged in the whole world is iodine deficiency. That doesn't exist in the States, in the United States, because our salt is iodized, so it contains iodine. Most of the common causes here in the United States is what we call autoimmune disease, in which case the body doesn't recognize the thyroid tissue and they attack it and they grow. That's what we call Hashimoto's. Now, there's also what we call goiters, which is a common layman terms, which is enlargement of the thyroid. You have to classify that to toxic and non-toxic. Toxic means to say it's producing a lot of hormones, in which that goes to what we call the Graves' disease, or non-toxic, which we call euthyroid. You can also subclassify this further into simple, which is secondary to hormonal changes. The second is sporadic, which is nobody knows what's the cause. And lastly is the endemic, which is I just said iodine. But that doesn't exist here in the States. It's predominantly autoimmune disorder.
Which is a really hard thing for someone to sort of combat and also try to prevent, right?
There are risk factors for goiters, like for example, if you have rheumatoid arthritis, type 1 diabetes, those are autoimmune disease, history of exposure to radiation, and sometimes the age, they're usually the middle age. Females has a ratio of 3.9:1, has more enlargement of the goiter compared to men, and those are risk factors. It's advisable that when they go to their annual checkup or the primary care follow-up, usually our primary care in GBMC are very thorough, and they will top head to foot, and they will examine. I've seen patients that they didn't even know that they have an enlarged goiter until their primary care really looked at them.
And women seem to be affected more because of hormone fluctuation? Do we know?
Well, we don't know at this moment because there is still statistics. The statistics has to be really examined carefully where there's a female predominance.
How about when, let's say the thyroid is not enlarged or noticeably so, but it's just not functioning properly? What are those kinds of disorders?
Those are what we call hypothyroid disease, and those hypothyroid diseases are basically more of medical. We usually don't operate on them unless there are clinical or surgical indicators. Now, the hypothyroidism may be secondary to a burnout thyroid in which it doesn't anymore produce hormones. So usually the treatment for that is usually medical. The only time surgery will be indicated is when there is a nodule that is suspicious on ultrasound, in which case we do a biopsy of that. Usually our endocrinologist or even us will do the biopsy if there's anything suspicious. But hypothyroidism is a medical disease, and unless, of course, there are clinical and surgical indication, in which case we have to make sure that the patient be what you call this in euthyroid state before we do surgery.
And what's the difference between hyper and hypothyroid disease?
Hyperthyroidism is when the thyroid produces the hormones T3 triiodothyronine and T4, which is thyroxine. There's an increase in abundance of those thyroid hormones, resulting to symptoms like tremors, palpitation, coarse hair, and sometimes palpitations and cardiac issues. Hypothyroidism is when the gland fails to secrete sufficient thyroid hormones, in which case you develop signs and symptoms of hypothyroidism, sluggish, fatigue, and other side effects of hypothyroidism. And this is easily determined by thyroid panel, which is T3, T4, and TSH. I think the first order of business is really to go to your primary care physician. And from the primary care physician, they will examine you whether you need thyroid treatment or not. They are very, very thorough on this. They will run all the questionnaires for hyper and hypo. And from there, based on clinical grounds, they will feel the neck and see if there's enlargement. And the next step, of course, is that labs, then ultrasound.
Is Graves' disease the same thing as hyperthyroid?
Yes. So Graves' disease is most likely will produce high hormones like T3 and T4. The Graves is an autoimmune disease which is actually targeted by the body's specific receptor, the TSH receptor. That's 91.2% exist in those kinds of patients. So Graves' disease is predominantly, if you're in Graves' disease, the first thing is to do medical control, which is non-surgical. There's a lot of thyroid medications for that, and you can even do radioactive iodine. Now, there is also surgical indications for that. It's only when the non-surgical component fails or the patient does not want to be treated with radioactive iodine or even side effects of the medication, will surgery be considered.
How common are these conditions?
Well, the thyroid exists in 24.9 per 100,000. So that's the more or less the statistics that's so commonly laid out there in our internet.
So it's not uncommon. Might not be
It's not
common, but it's not uncommon.
agreed, but sometimes they are what we call asymptomatic. They don't know whether their thyroid is enlarged. It's only when they see it in the mirror, they feel the neck, then they notice it. Or when they see our primary care physician, GBMC, then they say, hey, there's something wrong with your thyroid gland. Or during an workup for another disease, and when they do imaging and they find, hey, the thyroid is enlarged.
Are there certain things that we should be on the lookout for that may mask themselves as symptoms of other things, but really are simply an issue with the thyroid?
Well, there are signs and symptoms that is related to the thyroid. It's more of compressive symptoms. Okay, let's go now to the structure first. If you're having difficulty in swallowing and having pressure in your neck, you should have your primary care physician take a look at that. Now, if you're having signs and symptoms of hyper and hypothyroidism, the first you need to talk to your primary care because you need to differentiate whether hyper or hypothyroid. The management is different.
Is there a message that we could give people who might be watching who may be experiencing some mild symptoms and they're questioning what's happening with their thyroid, but they're saying to themselves, it's COVID right now, I don't really want to deal with it, just to let them know that there are options for them that are safe?
Yes, there are options for them to be safe. In the first place, if they have all the symptoms of hyper and hypothyroidism, which we discussed earlier, or if they have compressive effects, it's a quick visit to the primary care and they will do an ultrasound on this. And based on the first two steps, then because of COVID, because of the elective cases are canceled right now temporarily, then if it's benign, they will probably manage conservatively. If it's malignant based on ultrasound, then they will do a needle biopsy or go ahead with surgery. There is always avenue. COVID is not I know COVID is there, but if your symptom is getting worse, then I suggest you go first to your primary care physician for a full workup.
And of course, if it's malignant, that is not elective surgery. That is something that will be seen to immediately, if necessary.
Yes, one of the cancers, the survival of thyroid cancer are pretty good. Even with that, in GBMC, if you're diagnosed to have cancer, we don't delay. There's no restriction here. If you need surgery, we will do surgery.
All right, Dr. Ray Blanco, the medical director with the Milton J. Dance Jr. Head and Neck Center. Thank you so much for joining us today. We are going to spend some time talking about thyroid cancer, as you know, with Dr. Farzad Masaroa, who's joining us very shortly right after you. So we don't want to neglect that whole segment of conversation. But thank you for joining us and talking about the other issues facing the thyroid and exactly what the thyroid is. And take care of yourself and be well.
Thank you, too. Have a nice day.
You too. And we just mentioned we are going to be talking about thyroid cancer and talking about the options that are available. And we did have a nice interview with Dr. Masaroa, and we're going to play that now so you get to know a little bit about him.
I was exposed to medicine from a very young age, and I realized that what I really enjoy about it, and probably what's different from medicine from most other fields, is the kind of the patient-doctor relationship and how it's a special type of relationship, and to help someone through sickness is something which I thought that I could be very good at. The Milton J. Dance Jr. Head and Neck Center has a very long history and a stellar legacy in treating head and neck patients. This center was founded nearly 40 years ago. Part of that legacy also means that the staff here and the system they have built here is top-notch. Head and neck surgery, the term encompasses various categories. One of them would be the surgical management of benign and cancerous tumors of the head and neck. Oftentimes, these patients who have had these tumors removed have deficits, that need to be reconstructed. So that's the second category of my field, reconstructive surgery of the head and neck, usually for patients who have had cancer surgery. It can also apply to patients who've had trauma or have had complications from other treatment modalities like radiation. And then there are other sort of subcategories as well, like salivary gland surgery, thyroid surgery, that all fall under the umbrella term of head and neck surgery. Most patients that I'm seeing are usually being referred to me because they have a suspicious finding either picked up by their doctor or themselves, which is worrisome for a tumor of the head and neck. Likewise, if they have throat pain or some difficulty swallowing, that may lead their doctor to discover that they have something happening in their throat that may need surgery to help fix and cure them. A lot of patients, when I see them for a potential tumor or cancer of the head and neck, they are worried that it's a death sentence, and that is not necessarily true. Like, a lot of these cancers can be cured, and some of them can be cured with minimal side effects or minimal loss of function. At least over here in the Milton J. Dance Jr. Head and Neck Center, we're very conscious of treating everyone as if we would want our families to be treated. Our jobs is not just to be a surgeon and technician. Our job is to also basically be kind of your guardian in your ward and to help you really get through treatment. At our center, we have various, not only doctors involved in your care, but we have various allied health professionals as well. We're all working together really for the head and neck cancer patient. When you meet a patient, it's a very special relationship. They show a lot of trust in you, and that's a very special thing. It's a privilege to treat patients who are approaching you with that sort of mindset. I feel like my work has a lot of meaning, so I feel very blessed and lucky to be able to do that. And I really do mean it that it's a privilege for me to be involved in these patients' care.
And joining us now live is head and neck surgeon, Dr. Farzad Masaroa. Thank you so much for being with us.
Thank you. Thanks for having me.
That was a great story. It really gave us a sense of what you do. And it was a very warm feeling and a comforting feeling, I think, that patients must feel when they come to you and all the team to deal with whatever they are dealing with as far as head and neck goes. And I have to say, too, I've heard to be a surgeon for head and neck issues, that can be kind of complicated. It's all complicated in there, isn't it?
Very complicated. The real estate is, high value real estate, not a whole lot of space. And so, things, if a person has a head and neck problem, a head and neck cancer, it's unfortunate that oftentimes a lot of important things can affect it. The way we interface with the world, the way we interact with the world is through our head and neck, and all these things can be affected.
One of the most uplifting things I heard out of that video is that thyroid cancer can be very, very treatable.
Absolutely, absolutely. The most common type of thyroid cancer is something that I'll refer to, and a lot of us surgeons refer to as differentiated thyroid cancer. And what that means is that, it's cancers like papillary thyroid cancer, follicular thyroid cancer. And these cancers are, the prognosis is very good. And with a good surgery and a good treatment team, most patients can be expected to be cured of it.
How many different types of thyroid cancers are there?
Roughly. Good question. So roughly, well, a lot. But I would say it's helpful to think of it in terms of three groups. So the first group is something we call differentiated thyroid cancers. And what that means is that the cancer has originated from the lining of the thyroid gland called the follicular epithelium. And those cells are the cells that are responsible for making thyroid hormone. And that's probably about 85% of thyroid cancers. And within that category are some other groups like papillary thyroid cancer, follicular thyroid cancer, Hürthle cell thyroid cancer. And that all is under one category called differentiated thyroid cancer, which is by far the most common type of thyroid cancer. The second group is something called medullary thyroid cancer, which comes from a different cell in the thyroid gland. It's the cells called the parafollicular C cells, and these cells are responsible for producing a hormone that helps control your calcium. Those cancers are not as common, a little bit more aggressive, and fortunately not as common. And the least common category is something called anaplastic or poorly differentiated thyroid cancer. These cancers, fortunately, are very rare, probably under 3% of thyroid cancers, and these cancers can be very aggressive and deadly.
What are some of the most common symptoms that we should be aware of?
I would say when thinking of how a thyroid cancer can make you feel, it's helpful to remember what are the organs and structures that are near the thyroid gland. So, number one, you have your voice box, which has your vocal cords. So if you have a thyroid cancer that's pushing on that area, you may sense a change in your voice. The second is your windpipe, also known as the trachea. And if you have a cancer pushing on your windpipe, then you may have a change in your breathing, or a little bit of a noisy breathing or difficulty breathing. Another structure is your swallowing tube, also known as the esophagus. And if you have a cancer pushing on that, then you may have some difficulty swallowing. And another important structure is something called your recurrent laryngeal nerve, and that is a nerve to the voice box. And if that is being pushed on by a thyroid cancer, then likewise you can have a change in your voice or hoarseness.
And I'm sure it's different for different types of cancers, but do we have a sense of some of the things that we might be doing that could lead to this type of cancer, or is it genetic? I'm guessing smoking may play a role?
I think smoking is probably, is never a good thing, and will increase your risk for all types of cancers. But a lot of thyroid cancers, some of them, the risk factors are a little different. For example, a strong risk factor, but is not very common, is having a history of radiation to the neck. So historically, we would give radiation a lot more for various reasons to people when they were younger. For example, if they have lymphoma, in their neck that got treated with radiation, or some patients may have gotten radiation to other parts of the body, and the neck was within the radiation field. That can greatly increase your risk of having a thyroid cancer. Differentiated thyroid cancers, which are the most common type of thyroid cancers, those are more commonly found in women for some reason. So about 3 times more common in women than in men, and it affects women usually between the ages of 40 to 60. We know that being overweight has a link to thyroid cancer too, and thyroid nodule formation. So those are some of the common risk factors. And you can also have some genetic conditions too. Some thyroid cancers can be hereditary, and especially the second category that I talked about before, medullary thyroid cancer, has a strong linkage with hereditary genetic conditions.
Does a diagnosis of thyroid cancer most often involve surgery?
It does, yeah. A good surgical operation is needed in most thyroid cancer. For example, in differentiated thyroid cancer, a good meticulous surgery where the cancer is removed in its entirety with 3-dimensional margins, and making sure that the lymph nodes in the area are checked adequately before surgery and during surgery. That can really, that is probably the most important step in thyroid cancer treatment. Afterwards, we do use things like radioactive iodine for differentiated thyroid cancer too, which is it's something whereby a iodine is tagged with a radioactive element, which can, in a manner, kind of like a Trojan horse, because thyroid cells are really the only cells in the body that take up iodine. So radioactive iodine is tagging a radioactive element with iodine, and the thyroid cells pick it up, and they're the only ones that get poisoned by it. But that has a role too. But good surgery is by far the most common modality.
So is using the radioactive iodine, is that sort of in place of chemotherapy?
Sort of, yeah. Chemotherapy also has a role too, and especially for cancers that have spread to distant parts of the body that are not curable, that cannot be cured in any way by surgery or radioactive iodine. A lot of these thyroid cancers, for example, when they become very advanced and have spread to a lot of different parts of the body, they will actually become, the term we use is refractory to radioactive iodine, meaning the radioactive iodine doesn't work anymore. And in those cases, especially, chemotherapy can keep the cancer in check, and actually it can keep the cancer in check for many, many years.
What is the recovery like for someone who has had thyroid surgery for cancer?
Surprisingly very good. A lot of patients can go home the same day. It depends on the extent of surgery. So for example, if you have a small cancer that is under 4 centimeters, in one part of the thyroid gland that has not gone beyond the thyroid gland, does not have any other bad features to it, then removing just one half of the thyroid gland, and that procedure is called a thyroid lobectomy, can be curative for the patient, and those patients can go home the same day from surgery. If you do a little bit more involved surgery, say you remove some of the lymph nodes and underneath the thyroid gland, these lymph nodes are called the central neck lymph nodes. If you have to remove those lymph nodes, or lymph nodes on the side of the gland, on the side of the neck, what we call the lateral neck, if you have to remove those lymph nodes, then you can expect probably at least 1 day in the hospital, and most patients will go home after 1 day in the hospital. A thyroid surgery is surprisingly not very painful. And most of the time, I do not use drains in the surgical wound. It's not needed, and so patients will go home and they'll take Tylenol and ibuprofen for pain. Nothing stronger than that. They'll start eating the same day and go back to regular diet the next day and feel surprisingly very well.
And then how is it managed? Because you've had this thyroid removed.
Mm-hmm.
What do you have to do to now replace it?
Good question. So one of the advantages, for example, for removing just one half of the thyroid gland is that about half of patients then do not need to go on to thyroid hormone replacement. They don't need to. If you remove the entire thyroid gland and there's no more thyroid gland left in your body to make thyroid hormone, then you have to go on a pill, which is basically a thyroid hormone replacement. But if you've only had half of your gland removed, then you don't need to do that. The thyroid hormone pill replacement is you take it in the morning, about an hour before eating breakfast on an empty stomach, and the way we determine how much is the right thyroid hormone you're getting is based on blood tests, which can be done every 3 to 6 months to 1 year, depending on what kind of dose, on the stability of the dose you're on.
Do you have to cut back on salt or anything like that?
No.
So nothing has to really change. Pretty incredible. How about therapies? Would it affect your voice at all?
Good question. During thyroid surgery, the nerve that goes to the voice box controls your vocal cord on that side, and that is probably the most important thing to pay attention to while doing thyroid surgery. If the cancer is not involving that nerve, which most of the time it does not, then that nerve should be spared, and it should be not injured during surgery, and your voice should not change. If the cancer is a little bit more advanced and it's invading the nerve, then that nerve may have to be sacrificed to make sure all the cancer is out, and then you can expect your voice to change. Luckily, there are other procedures we can do afterwards, and we work closely together with our colleagues in our voice center at the Milton J. Dance Jr. Center, and we can help the voice come back to normal. But it really depends on the extent of cancer, on whether your voice will be permanently affected.
Would you say that even in light of the current COVID situation, that it's important for people to really be in touch with what their symptoms are, and if they really think that they've got something going on, that they can still seek help?
Absolutely. It's a lot of, for example, some patients will feel a lump in their thyroid gland or in their neck, and it's important to get that checked out. And even though COVID is happening, and especially in the last few months, it's really caught fire and it's affecting a lot of things. The thyroid gland and a biopsy can be done safely in a way whereby we minimize your exposure to COVID, and you should be fine.
Dr. Farzad Masaroa, thank you so much for joining us today and talking about your thyroid cancer. I feel there's a great deal of optimism with that diagnosis, and appreciate you being here to tell us more about it.
Thank you. Thanks for having me.
Yes, and be well.
You too.
And thanks to everyone for joining us today on Greater Living.